Dear colleagues, the next episode in our series about planning and carrying out an orthodontic treatment is about the easiest for diagnostics but most complicated for execution approach to Class 3 treatments, orthodontic-surgical treatment. In this case we will begin with an orthodontic treatment and a little bit before its end, an orthognathic surgery for correction of the jaw's relationship and the asymmetry. Sometimes the opposite order is possible, surgical correction to be performed first and the orthodontic one next. These complex treatments are always carried out in close collaboration between the surgeon and the orthodontist. Here I would like to say thank you to Dr. Poliranov and Dr. Zorov for their efforts on this young lady's case. The patient is 29 years old, female with main complaint, overdeveloped mandible and facial aesthetics. You can imagine how these problems reflect on life, social contacts, and personal and professional realization of a young girl. Her nasolabial angle is normal, but her profile is concave, and she has a noticeable facial asymmetry because of the laterognathia of the mandible to the right. Fortunately, she does not complain of TMJ problems. Her face is visibly elongated, maxillary midline is shifted to the right and there is a cant in the smile. Even more challenging was that the patient lives in Germany and planned to fly for her appointments once in every 3 months. Intraorally we find missing upper canines and lower incisor. Severe Class 3 occlusion and crossbite of frontal teeth. Bolton discrepancy with microdontic lateral incisors and medialization of maxillary left teeth. Because of the missing lower incisor, an ideal Class 1 occlusion can be achieved for the maxillary premolars, which are going to replace canines at the end of treatment by placing lower right canine at the place of a lower incisor. Microdontic lateral incisor is among the main causes of retention of maxillary canine, as you will find out in another episode of my series. Skeletally we can observe a severe Class 3 with hyperdivergent growth pattern. Normal position of maxilla and upper incisors but overdeveloped mandible and seriously retro-inclined lower incisors -20 degrees under the norm, which have tried to compensate for the overdeveloped mandible and due to the pressure from the lower lip have tried to reach contact with the upper incisors. The OPG shows that wisdom teeth are also missing but also that 13 has been retained. The bigger than normal dimension of the canine means it is closer to the X-ray detector, therefore it is palatally situated. The obturation of maxillary right first molar harms the periodontium and needs to be corrected. There are endodontically treated molars and a cavity of maxillary right second premolar. We can also notice a pneumatized maxillary sinus. There is an asymmetry of the mandible including the condyles. So, the aim of the surgical intervention, which will be performed only in the mandible, is clear: first, to shorten and move it backwards; second, to reduce the facial height by changing the angle between the body and the ascending ramus of the mandible; third, to correct the symmetry of the mandible. The purpose of the orthodontic treatment is to prepare the dental arches for surgical correction. It begins in April 2011 after extraction of the retained 13 with bonding of braces. The first arch wire is 014 thermoactive. The next step is to include the second maxillary molars after 2 months with 016/022 thermoactive wire and bonding of the mandible with 013 leveling wire. The aim of the leveling in mandible is to normalize the inclination of the lower teeth. After 8 months, upper and lower dental arches are leveled and aligned, and we already have stainless steel arch wires in place. Now is the moment for upper midline correction by moving it to the left at the center of the face with an elastic power chain. In 1 month, the upper midline is at its place. So, 11 months after the beginning of treatment, it is time to take control photos, OPG and impressions. This is an obligatory stage in any of mine treatments to analyze what corrections that are needed to finalize it. Control impressions are of utmost importance for orthodontic surgical treatments because the models show how will dental arches fit during the surgery. The task of the orthodontist is to align teeth in such a way to achieve maximum intercuspidation and normal transversal and sagittal occlusion in surgery. That will ease fixation, immobilization, and will improve the prognosis after operation. OPG is needed to check the parallelism of the roots. Half a year later the second lower molars have been leveled and fit the models of the maxilla. The inclination of the incisors is normal. The reversed overjet reflects the difference in the lower and upper jaw base. The spacing in the maxillary dental arch is also solved. In the photo below, the impressions of teeth on the tongue are noticeable, as a symptom of macroglossia. The next step is a surgical correction of the tongue, to reduce its volume as a prevention from relapse in expansion of the mandible. There are different opinions in the literature on the stability of this operation and its necessity, but in this case, it has been made for greater certainty. You can see the scars from the stitches. This is the control ceph before the operation. The skeletal class and the growth pattern are certainly not changed. Only the inclination of the incisors is changed. The maxillary incisors are proc-lined for more prominent upper lip, and the lower ones are greatly improved but not up to 90 degrees due to one lower incisor less. After new control impressions, the next plaster models were cast for inspection just before the operation, for discussion with surgeon and production of surgical splints. Once we are satisfied with the maximum fit of the two dental arches, I change the arches to 0.21/0.25 steel with surgical hooks in 0.22 slot and the operation is scheduled. The hooks are used for fixation during and after the operation between the maxilla and mandible. Notice where I put the middle hook in the mandible, it must match the upper midline to correct the asymmetry of the lower jaw. Thus, the surgeon orients himself about the necessary movement of the mandible, more to the left during the operation. Here she is a month after the operation with significantly improved facial aesthetics in both profile and facial symmetry, as well as facial height. Note intraorally how maxillary midline fits between the contact of mandibular right central and lateral incisor. At this point, a full intraoral photoset is not possible due to limitation in opening of the mouth so early after the surgery. After 2 weeks, she opens her mouth enough so that I can change the arches and finalize her treatment. I use a lower braided arch wire in combination with intermaxillary elastics to achieve maximum intercuspation. Here she is, a month after the removal of the braces. She underwent her complete change in 2 years. The profile and symmetry are improved, and the upper midline is in the center of the face. She smiles happily after everything he has experienced. I wish you could see what happiness the eyes of these patients radiate, but maintaining confidentiality does not allow this. Intraorally upper premolars which have replaced canines occlude in class 2 because mandibular right first premolar replaces the canine. Thus, canine replaces the missing incisor, and the middle of the mandibular dental arch is between right central and lateral incisor and coincides with the upper midline. Fixed retainers for at least few years after the treatment and an upper removable appliance are mandatory in all cases with a significantly changed width of the upper dental arch. The final ceph after the operation shows a clear change in the skeletal class with backward movement of the mandible by more than 4 degrees and 6 millimeters. The incisors are proc-lined. There is also a slight decrease in the SNA angle, with point of following the roots of the upper incisors as they move palatally when they are being proc-lined. You can also see the change in the chin after the genioplasty. More than a year after the treatment, the smile is still so beautiful. The stability of the treatment is excellent for both the surgical and the orthodontic part. You see the stable occlusion at the end of the retention period. Pay attention to the frontal photo, how the lack of the incisor is not noticeable and how successfully it is mimicked by the right canine. We have good intercuspation although quite untypical occlusion due to the missing canines and lower incisor. On the SN plane superimposition, we have a significant displacement of the mandible back at the end of the treatment in red compared to the initial situation in black. In this way the profile changes along with the facial height and symmetry. Based on the upper jaw, we see the proclination of the incisors with controlled typing, i.e., rotation around their center of resistance. In the mandible a dentoalveolar proclination of the incisors is noticeable. On this slide the change, before the 2-year treatment and the retention control more than 1 year after treatment are compared. The blue lines are placed on the teeth that replace the canines to illustrate the canine class. The change in occlusion is also visible even to non-specialists. We can trace the change in the patient's profile, before treatment and 1 year after treatment, as well as in the symmetry of the face and smile. In my opinion, only orthodontics is capable of such a change, especially with natural teeth. Change not only in the vision but also in the destiny of the person. I hope to inspire you to study it in depth beyond the simple bonding of braces or putting on appliances. To love this specialty and think about each case individually and not in the template deformation appliance, such as Class 3 expander with a face mask. This is the real orthodontics, what you will do with the braces and how. Thus, you will have happy and satisfied patients. Thank you for your attention. See you soon in the new episodes of this series presenting the magic